Hello and good day to you. My name is Tracy Harrison, and I want to invite all progressive healthcare practitioners, wellness practitioners from all modalities for practitioner tips from the School of Applied Functional Medicine. Today we're going to be talking about common practitioner missteps in resolving metabolic dysfunction, which is a critical topic for all of us to master because of the widespread, I would say, epidemic prevalence of either clinical and diagnosed, clinical and undertreated, or subclinical, often missed metabolic dysfunction that is at the roots of our patients and clients' suffering. Metabolic dysfunction influences the cellular metabolism and the function of any and every tissue in the body. And so whether your expertise is fertility or autoimmune disease, or atherosclerosis and cardiovascular dynamics, we all need to master making sure that we catch metabolic dysfunction at whatever stage of progression it might be, and that we are keen and really savvy and effective at resolving it. At the School of Applied Functional Medicine, we've been educating a rich diversity of thousands of practitioners around the world for nearly 12 years now. Just short of 5,000 students hailing from 22 different modalities and dozens of countries around the world. But I want to talk about Jane. Jane is your typical woman in her 40s or her 50s that right now, meeting with her primary care provider in maybe an annual physical appointment. Maybe she feels well. Maybe she's not complaining very much. But 10 years from now, Jane is going to be diagnosed with type 2 diabetes. And I think one of the biggest missed opportunities that we have in our practices today is that we are not looking for the early cues and clues, the warning signs of metabolic dysfunction, so that we can alert, we can inform, we can educate and inspire and empower the patient to do something differently so that the next 10 years doesn't unfold in actually a very predictable way to create type 2 diabetes and the years and years of glycemic mediated oxidative damage that it's going to create. Because by the time we diagnose type 2 diabetes, Jane has already been suffering. Not only has she likely gained quite a bit of weight, including quite a bit of obesity, the progressively increasing blood sugar, and before that, the elevated levels of insulin have likely already been promoting in Jane things such as fatty liver, such as damage to the precious endothelial lining of her blood vessels, oxidative damage to her kidneys, to her retinas, to her nerves that we know over progression can create diabetic neuropathy. So we want to help Jane right now, way before blood sugar increases. And if you only take away one pearl from today, this is what I would encourage it to be, because research shows that we start to see a subclinical increase in fasting insulin or fasting C-peptide as much as 13 years before Jane's diagnosis of type 2 diabetes. Collectively, we can make a massive difference by assessing and identifying this dynamic and telling Jane about what is at play and inspiring her about the power she has to avoid type 2 diabetes, to prevent type 2 diabetes. Because what otherwise does Jane do? Otherwise, we look at blood sugar. It's not elevated, subclinically or otherwise. It's perfectly fine. It might even be optimal, or it might even be surprisingly low. I'll come back to that in just a second. But in the absence of flagging anything, Jane hears what? She's fine. Everything's fine. Good job, Jane. See you next year. And what does Jane do? She keeps living the exact same lifestyle she was living before, thinking it's healthy, thinking it's promoting a good, resilient vitality. And unfortunately, that is not true. The biggest miss is the opportunity to empower the client, the patient, with knowledge to make different choices about their diet, different choices about their exposure to toxins, especially personal hygiene and beauty products, the chemicals in which are known to be obesogenic and can be at the roots of driving metabolic dysfunction. But also stress, completely separate from diet and toxicity. Stress on its own promotes a higher glycemic load of the lifestyle, if you will, and can create insulin resistance and progressive metabolic dysfunction. But if we were to assess fasting insulin or fasting C-peptide, we can see the pancreas begin to make step by step adaptive increases in insulin release in anticipation of needing to manage a higher glycemic load. Now, this is a great example of the fitness, the adaptability of the body. The pancreas has been sensing this higher glycemic load, and it's just sending out more insulin in anticipation of that. But often this is happening for years and years before pancreatic adaptive response fails, because we don't see blood sugar begin to go up until it has failed. And the human body is incredibly resilient, as we know. And so often the pancreas has been doing this for years and years, or as studies have shown, as much as 13 years before we see the failure. And so if Jane gets the feedback of "you're fine" versus Jane getting feedback of, well, I took a look at these predictive markers, right, where your body is adapting to some higher demands. And we know it can do that episodically with no issue whatsoever. But now is a great time to take a look at your lifestyle and your choices that are requiring that your pancreas work harder and harder to support you. If we engage now in order to make different choices so the body doesn't have to work as hard, we can likely bypass the development of oxidative stress and damage. We can bypass the development of fatty liver, bypass the development of increased obesity or increased fatty incorporation into skeletal muscles. We can increase your energy. We can avoid type 2 diabetes and its downstream complications of metabolic syndrome. So insulin or C-peptide can be valuable fasting markers. C-peptide, unfortunately, is not caught on yet with widespread popularity in terms of being a typical annual physical wellness lab array, but I hope it does, because fasting insulin is not either, but at least fasting insulin is more readily available. The challenge is that fasting insulin can be a bit more labile versus fasting C-peptide has a longer half-life and is a bit more stable. But think about including these markers specifically into your lab work, because we don't see blood sugar, hemoglobin A1C, beginning to trend up, much less trending high enough to be diagnostic of even prediabetes until we are in the third of 4 stages of metabolic dysfunction. And I want to just describe to you briefly what are those stages. At SAFM, we have an entire 9-hour course on reversing metabolic dysfunction, and we speak about the 4 stages. And indeed, well before blood sugar goes up, what actually tends to happen is that adaptive pancreatic response with higher and higher levels of insulin will grow and grow and grow to the point where what you see is actually hypoglycemia. The adaptive pancreatic response is now driving blood sugar down, and these individuals are starting to complain of episodes of reactive hypoglycemia, or being hangry often, or feeling like they need to eat 5 or 6 or 7 times a day in order to not feel angry, or lightheaded, or foggy brained, or really sluggish energy and exhaustion. This is your cue to look. And it's also a reminder that when you see lab results that are surprising or inconsistent with the lifestyle choices that a patient is making, even though the lab marker value may be what we often call optimal, we always want to question, just with our wisdom, when a person is eating a standard American diet and having the standard American amount of stress, why do they have a fasting glucose of 85? That doesn't make any sense, given the high preponderance of blood sugar surges because of our stress, given the high preponderance of high glycemic, highly refined carbohydrate foods in the standard American diet. What you may find when blood sugar is surprisingly low, when hemoglobin A1C is surprisingly low, you may find that their fasting insulin or C-peptide has trended up. And so look at the early stages of metabolic dysfunction in the people who are just complaining, maybe even lightly, about symptoms of hypoglycemia, because hypoglycemia will nearly always present before the hyperglycemia. And you can catch that many years prior. And this is often when the pancreatic adaptive increase in insulin secretion is trending upward, and it's not quite clinically high, but it's trending up into the upper half of the normal range, right? A great reminder that normal ranges are not healthy ranges at all. They're just literally the statistical norms that patient populations are presenting with, the 95% of a given lab population. We want to look for optimal zones of lab markers, not normal ones, because there are plenty of people with brewing metabolic dysfunction inside normal ranges for fasting glucose, for fasting insulin, and certainly for hemoglobin A1C. Another thing we may want to look for is measuring hemoglobin A1C also as a annual, even annual physical lab marker. And this is because fasting glucose is often the marker that is relied upon, very inexpensive, readily accessible lab markers. But as we know, fasting glucose levels and hemoglobin A1C levels can be notably different in either direction. And this has to do with the fact that A1C, assuming people are not notably anemic, which is going to make hemoglobin A1C not reliable. But in the absence of notable anemia, iron deficiency anemia, hemoglobin A1C is a much more reliable marker because it is assessing the glycemic effect of blood sugar over the life of red blood cells. So it's not a single episodic marker like fasting glucose is. Fasting glucose can be highly influenced by a person having had a really poor night of sleep the night before. It can be heavily influenced by a person having a very stressful journey to the lab on a weekday morning to get the blood draw that they needed. Or maybe they had an argument with their teenage child. If an individual is struggling with lots of stress in their life and they are operating right now in a hyperadrenal state where their cortisol levels are notably high, maybe their cortisol awakening response is aggressive, they've been going through a lot of stress and crises, and so their adrenal gland is also having an adaptive response, and it's putting out excessive levels of cortisol in anticipation of lots of stress in order to protect a person. Right? This is part of the adaptive resiliency of human physiology. But those high levels of cortisol first thing in the morning are going to drive their fasting glucose way up. And so you may see really notably high fasting glucose, but optimal hemoglobin A1C, or really low hemoglobin A1C. Or you may find it inverted. You may find a situation where if you only looked at fasting glucose, it's perfect. It's optimal, right? But then if you were to check hemoglobin A1C, it is notably elevated. We need to be checking both. And I want to encourage all practitioners to become incredibly savvy at interpreting how do I respond to all the different combinations, because you can learn so much from everyday annual physical lab work. At SAFM, we teach about all sorts of different functional labs in order to get that edge of technology glimpse into functional physiology, and they're incredibly valuable lab panels. But first of all, we teach all practitioners how to gain as much value as possible from a much deeper interpretation, a more keen interpretation of everyday annual physical lab markers, because generally the signs, the cues and the clues of progressive disease are in that everyday very affordable, very accessible set of lab markers, and we just don't know where to look. It's a huge missed opportunity for the patient and the practitioner alike. So it's really critical that we learn to master these concepts, because we can help people to get in front of this dynamic and prevent the downstream damage that happens when metabolic dysfunction is allowed to just progress year after year after year and then be diagnosed as maybe pre-diabetes after it's been doing damage to human physiology for years and years. In particular, damage to the kidneys, damage to the lining of our arteries, damage to our eyes, and damage to our nerves. Oh, and there's a reason why metabolic dysfunction is often the gateway diagnosis to a huge set of other systemic disease dynamics. And we know that. We expect that in things like metabolic syndrome that can lead to atherosclerosis and cardiovascular events that can be life-threatening. But it can also be the gateway to dysfunction in the liver, dysfunction in the kidneys, dysfunction in the nervous system that can precipitate to all sorts of other downstream suffering. And so we want to learn to master responding to metabolic dysfunction. And I want to raise an interesting related point because what we often don't think about as either a downstream effect of metabolic dysfunction or, for that matter, an upstream contributor to metabolic dysfunction, and that is the gut. Pretty much disease of all types, including metabolic dysfunction, begins in the gut. And indeed, as much as I want to promote that we change clinical practice in metabolic dysfunction, the area of functional physiology that we most all need to master is the gut. Because we so often don't remember, and many of us are not taught in our foundational training, that the triggers, the mediators for insulin regulation happen in the gut. We're so enamored with our GLP-1 agonist medications that are available today and are quickly becoming the blockbuster darlings of pharmaceutical solutions for metabolic dysfunction. But incretins, a GLP-1 is an incretin, are triggered in the gut, right? It is gastrointestinal emptying from the stomach that triggers the release of GLP-1 that helps to ensure sufficient, hopefully optimal levels of first-pass insulin response. This means that GI motility is at the center of optimal metabolic function. And for individuals who have sluggish GI motility, then we should actually logically expect them to eventually struggle with metabolic dysfunction, to eventually struggle with some type of poor insulin signaling. When we have, for example, delayed gastric emptying, we are not going to put out as many incretins. So we're going to have a lesser triggering of first-pass insulin response. It's naturally going to make us more vulnerable to higher blood sugar. For that matter, if people have rapid gastric emptying, then we're going to have a more aggressive level of incretins and a more aggressive insulin response, and that's going to make people more vulnerable to hypoglycemia. Well, there's an interesting vicious cycle here, right? Because we do all sorts of things that change our GI motility. And one of them is we have terrible eating hygiene. And this is one of the biggest ahas that you can give your patients and clients. Nothing seems perhaps more innocuous as the way we chew. Really, Tracy? Can that really have that much of an impact on anything? We think about chewing as being about manners. It's about hygiene, right? It's about slowing down and not being so stressed. But the reality is that we are naturally promoting GI dysmotility when we have crappy eating hygiene. So many people in our practices, maybe many of us, struggle to eat well, to eat in a way that actually promotes optimal GI motility and therefore promotes optimal metabolic function. Because when we are very stressed and we're rushing to a meeting, we may be cramming in some type of food, barely chewing, gulping it down, having to chase it with water because it's all dry in our throat. And people can feel the food kind of stack up, right? And they start to feel this early sense of satiety. And what tends to happen quickly after that is fatigue, because the GI tract feels like it's been assaulted with sudden massive intake of food. And because of the stress, We are not having optimal peristalsis. We are not having optimal GI secretions. And therefore, we are not putting out optimal levels of incretins to drive good metabolic function. So we want to teach patients about eating hygiene, about treating meals as a sacred time to relax, go into a parasympathetic nervous system mode, because that is the only way in which we optimally digest food and absorb nutrients and, yes, regulate our metabolic function. We want to sit down. We don't want to eat standing, much less walking or driving a car in traffic. We want to sit down, ideally pause, take a few slow breaths, slow inhales, slow exhales through our nose, not our mouth. And we want to relax, and we want to chew our food, put our fork down in between bites, chew it thoroughly, not chew it just to the point where we think we can choke it down, but chew it ideally to the point where it's largely liquid. It actually tastes sweeter the longer you chew it in your mouth. But of course, the chewing, the degradation we do in the mouth leaves less work for the GI tract. But there's a reason why we call the parasympathetic nervous system mode rest, digest, heal, and make babies. Because when the body is in a sympathetic nervous system mode and it's fighting, flighting, hiding, it's running, it's stressing, it's worrying about what it has to do next, it's cramming in a meal when there's really not enough time, the body doesn't give a rip about digestion because it thinks we're threatened. It thinks it needs to protect us for our survival. So it's not prioritizing secreting digestive fluids. It's not prioritizing GI motility. Of course not, because from an evolutionary viewpoint, that would have never promoted our survival. If we're running for our lives or trying to protect ourselves, historically, we would not be eating. We would not be worried about eating at all. We'd be worrying about surviving. This is a critical point of the art of lifestyle intervention and partnering with patients to help them to make changes. But there is solid physiological science between our stress state, our nervous system mode, our gastric emptying, and our metabolic function. And this is critical concepts that your patients are not going to know unless you teach it to them. It's a key part of the practice of functional medicine, right? It's a partnership between the patient and the practitioner where, yes, you need to bring a lot of wisdom, a lot of education, and a lot of interventional guidance. But the patient needs to change their lives and they need support. They need accountability and guidance on making step-by-step lifestyle change so that as partners, you can help them to prevent disease or actually to help them to reverse the diseases they're already struggling with, to promote active disease regression. And so there is a strong crossroads between the gut and metabolic dysfunction. And I want to tell you about another one that you might be unaware of. One of them is about the pancreas that I've been celebrating for a little bit here. The pancreas, as we know, has endocrine responsibilities in sending out insulin. Plays a critical role in getting sugar into the intracellular environment where it can be used by the mitochondria in order to make ATP and fuel the body, fuel all of our tissues. But the pancreas, of course, also has digestive responsibilities. It's a fascinating gland for this reason. And research shows that if individuals are struggling with any stage or any type of endocrine pancreatic dysfunction, they are way more likely to also be struggling with exocrine pancreatic dysfunction. So in your individuals in your practice who have pre-diabetes, entrenched type 2 diabetes, or for that matter, autoimmune type 1 diabetes, we want to be looking for cues and clues of maldigestion, because when the pancreas has been struggling with oxidative damage or perhaps intracellular hypothyroid function, or maybe an autoimmune dynamic, the variety of things that can directly cause the pancreas to not put out enough insulin. Odds are very high that it's also not putting out enough digestive enzymes either. And you can see this as they start to struggle with symptoms of maldigestion. So we want to be looking for this in our patients and clients, because if you don't, that suboptimal digestive secretion is going to lead to poor degradation of our food and leave a lot of dietary residue in our intestines and fuel microbial overgrowths or types of dysbiosis, maybe bacterial, maybe yeast or fungal in the gut. And this can promote IBS. There's a reason why there's a strong co-occurrence of IBS in people who have metabolic dysfunction. And often the pancreas is at those crossroads. And so we want to, again, be able to intervene before the natural progression of multifactorial disease is allowed to evolve. So think about the role of the liver. And bring in another disease dynamic, another body system. And in fact, we have an event that you can catch an on-demand replay where you can learn about many practitioner missteps in the realm of thyroid dysfunction, because we are learning that fatty liver, non-alcoholic fatty liver, that is so often at play in metabolic disease, often its very beginnings, its roots, are due to subclinical hypothyroidism, an incredibly common functional imbalance in the body, but often one that's overlooked because, again, we're waiting for lab markers to be clinically high, which may take years and years and years before we diagnose it and respond to it. But often TSH is perfect. TSH is not only normal, it may be ideal, but behind the scenes, there is intracellular hypothyroid function. And this is affecting the liver and causing the liver to not handle well the glycemic load coming from the gut. And this can be the beginnings of metabolic dysfunction. So we want to be looking for these early cues and clues. One of the things we can do, especially for women, is not just looking at TSH, but looking at a full thyroid panel. Because often TSH might be optimal, but unless you're looking at the other key thyroid markers, you're not going to see that devil in the detail that really tells you what's going on way in advance of TSH becoming elevated, even subclinically. And again, that may take years before that type of dysfunction is seen. But we want to think about where's that brewing behind the scenes, but also where can we be taking a look at liver markers and understand what might be at play. And unfortunately, people can have really entrenched fatty liver, and the typical liver function tests like ALT or AST may be perfectly normal or even optimal. It's actually an ultrasound that is much more likely to not miss fatty liver. But I would encourage you to also make sure you're looking at GGT, right? Gamma glutamyl transferase, because this is a marker that tends to be elevated into the upper half of the normal range when the liver is struggling with oxidative stress, when the liver is stimulating more synthesis of glutathione as a way of countering oxidative stress. And subclinical elevations can be a wake-up call that the liver is struggling. Now, it may be handling it fine, but similar to the higher glycemic load that the pancreas is handling just fine, or the higher stress load that the adrenals are handling just fine. We don't want to keep asking these critical glands and organs to do this for years and years and years, and eventually struggle to do so and create a more aggressive disease dynamic. We want to see where that struggling is happening early on and engage with the patient to educate, inspire, and empower them to make change now so that they don't need to keep leaning on that adaptive function, that it's sort of an adaptive hyperfunction, right? Just like anatomically we see episodic hyperplasia. The body is working really hard to respond to us, right? to help us, to support us through what we're going through. But when an episodic demand becomes a lifestyle, then we are waiting for a disease dynamic to become entrenched. And we've got to start lobbying in our practices with our practice managers in order to be more expansive and looking at some of these early warning signs of dysfunction so that we can actually prevent these disease dynamics from progressing. And I also want to talk about the microbiome, right? Who knew we were going to talk so much about the gut today? But the intestines also play a critical role in metabolic dysfunction because in the microbiome, we have a huge diversity of bacteria, as you know, that are all commensally interacting. And ideally, we are able to take good care of ourselves so that we avoid the use of antibiotics so that the microbiome can remain rich and diverse, so that we have a nice thick biofilm level and a nice thick mucosa in the intestine that is protecting that precious epithelial lining to support nutrient absorption. And there's a critical bacteria that's we've known for a long time plays a key role in metabolic function and in mucosal maintenance that's really started to see a lot more of a spotlight these days, which is Akkermansia. This is a genus of bacteria that has been heavily studied just in the past 7-8 years alone because of its critical role for constantly promoting the turnover of the mucosa and promoting high synthesis through its thriving of short-chain fatty acids. Short-chain fatty acids actually being produced by your microbial friends in your intestines. Short-chain fatty acids surely play a key role in the gut. They help to nourish the intestinal lining and they directly feed, for example, the colonocytes that line the large intestines. But short-chain fatty acids also regulate liver function. Short-chain fatty acids play a critical role also when stimulating GLP-1 levels, right? They help to determine the set point for GLP-1 release that regulates insulin. So if you think about it, if you back up, you want to be looking at this chain of interconnectedness, right? We want to be feeding our bacteria like Akkermansia so that they can be producing lots of short-chain fatty acids that can trigger good liver function and good GLP-1 levels so we can be triggered to produce optimal levels of insulin to deal with our glycemic load of life so that we don't develop insulin resistance and eventual metabolic dysfunction. This in functional medicine is what we call a chain of interconnectedness, right? It helps us to look across the artificial silo walls of anatomical and physiological systems. Everything in the body is interconnected. Everything in our lifestyle, in our life environment, in our behaviors, in our physiology is interconnected. We want to have good, rich levels of Akkermansia in our intestinal microbiome. And how do we do that? How do we help to nurture a really strong commensal environment in the population of the bacteria in the mucosa that supports Akkermansia? We want to consume lots of prebiotics. And this has to do with our diet. Surely there's lots of high quality prebiotic supplements that people can use as well. But this comes back to what are we feeding our microbiome with? If we feed the microbiome with a lot of sugar, I think most of us know that that tends to promote challenges with yeast overgrowth. It tends to promote higher priming of pro-inflammatory activity in the gut, where most of our immune system is housed. But when we're eating lots of plant foods, we're eating a rich diversity of fruits and vegetables and herbs in a variety of forms and a variety of colors also that belie the polyphenols that are in different foods, right? Different polyphenols in purple fruits and vegetables versus red ones or yellow ones or orange ones. It's the prebiotic fiber and the prebiotic polyphenols from this rich dietary rainbow that feed our microbial friends to start that positive cascade. Diet always matters. So many of the people we're serving in our practices are being told, yeah, eat what you want. That is poor guidance. It is, because diet matters hugely. The standard American diet today is very calorie rich and very chemical rich. But unfortunately, it tends to be woefully poor in micronutrition of every kind. And all of the body's biochemistry runs on micronutrition. Diet always matters. It always matters what people are eating, the quality of the diet. And we want to be fueling optimal microbial balance in the gut. Not only to prevent IBS, to prevent malabsorption of nutrients, to prevent immune dysregulation that promotes chronic allergy or asthma or autoimmune disease. But yeah, we want to be promoting a rich, diverse microbiome because of its impact on metabolic dysfunction. And so these are things that you want to have part of your daily clinical toolbox. We can all relate that there is a level of clinical satisfaction for you as a human being and helping someone to better manage their type 2 diabetes. But when you can help someone step by step in partnership over multiple sessions to resolve their type 2 diabetes, not only is that patient going to be a raving, ongoing fan of you and your practice and delightedly send people to your practice, there is no deeper sense of satisfaction and fulfillment for you than to know that on your watch, you did so much better than managing it. You did so much better than treating it. You partnered with a human being to resolve it, to take back control of their health, and to actually get out from under that predictable atherosclerosis, that predictable heart attack, that predictable Alzheimer that comes on the other side of that disease dynamic. And so I want to inspire all of us to reach for this much higher level of clinical outcome. Clinical outcome for your patients, which is a whole new lease on life and on the vitality of their body. But at SAFM, we value your outcome as a practitioner, your satisfaction and fulfillment on an equal level to patient outcomes, because doing this work, regardless of your clinical setting, regardless of your modality, doing this work is a commitment. It's a challenge. It's demanding. And we want you to find the deeply satisfying outcomes that help your heart to sing so that you can find the resiliency you need to keep doing this work. And we don't want it to become a standard of care that committed practitioners burn out and get exhausted, right? We want you to find that joy and that deep satisfaction that helps to light you up and fuel the path forward to be part of our mission for healthcare transformation. But one more thing I want to tell you about, it comes up all the time, supplements. My goodness, there are supplements that can be incredibly valuable for helping you to reverse metabolic dysfunction at all of its different stages. And I want to use this as an opportunity to tell you about the hundreds of free resources that are available on our website. There are hundreds of clinical tips that you can search by keyword. One of the things I want you to search on is inositol. Inositol is often referred to as a B vitamin. It is a wonderful intervention for helping individuals to reverse metabolic syndrome. It actually helps to overtly improve insulin sensitivity. It's been highly studied in particular for the metabolic dysfunction that is involved in women who have PCOS, but also studied, many practitioners don't know, with regard to actually dramatically improving insulin sensitivity so that the regression of insulin resistance can be more quickly achieved early on, in tandem, of course, with lifestyle change. Another one I want you to be aware of that you can check out on our website is berberine. Head-to-head in studies, berberine does at least as well or better than metformin. It actually has a similar mechanism of action in the intestines, but fortunately it does not have the terrible side effect that metformin does of impairing vitamin B12 absorption in the small intestines. But berberine, it's an extract. from a variety of different woodland plants, but it's incredibly powerful at helping to improve insulin regulation in the gut, specifically by improving the behavior of DPP-4 enzymes in the lining of the small intestines. That's where second phase insulin regulation comes in, something you can learn about richly. The other thing you can look up on our site is D-limonene. D-limonene is an extract from citrus fruits, which is often, you may have heard of it and you're trying to remember where it was. It might have been from household cleaning products. It's often included as an emulsifier in citrus smelling household cleaning products, especially degreasers. And it does a wonderful job of emulsifying fats, and it can actually be taken to have a similar effect in the liver. You take it orally. Of course, what we absorb from the gut goes into first pass hepatic clearance and can help to resolve fatty incorporation in the liver. And so just those examples right there, you can search to learn more about. There's great articles with hyperlinks to peer-reviewed full text articles that you can check out in order to see some of the evidence in favor of some of these formulas. But supplements can be valuable tools. At SCFM, we don't believe that supplements are an end-all be-all, because supplements without other targeted interventions tend to give only marginal superficial improvement or fleeting improvement. But supplements can be a valuable part of a clinical toolbox. And there are so many things you can learn about on our website. Thank you so much for being here today. And if you want to learn more about the School of Applied Functional Medicine and the transformative training program we have for practitioners in applied functional medicine, I encourage you to check it out. We have an accredited program that you can use for your CME and CE requirements, and you can begin to add the power of the functional medicine lens to your clinical practice so that your outcomes for your patients and for yourself are perhaps higher than you ever believed they could be. Thank you so much. Have a great day.